But we all learn from these mistakes, and I think certainly it makes us a little bit more wise for the next cases that come our way. So when thinking about my worst tibial complication, I look back at some of the cases. I often do tibial bypass, but I do like to attempt endovascular approach and not burn bridges for someone, especially with someone with poor conduit. So these cases can be quite challenging. Certainly in the presence of more extensive proximal disease, the cases can be very long and complex. So anyone that tells you it takes just a couple of hours to do these kinds of cases is, I guess, not done enough of them. So they're important to prioritize your revascularization strategies when you go into a case like this with a patient that's challenging with multi-level disease. And really pace yourself, be practical, and kind of just take step by step to reach the goal of limb salvage. So this case is that of a 65-year-old female who had a lot of compliance issues. She was a heavy smoker, coronary disease, prior RCA stenting, poorly controlled heart failure and diabetes, leading to some cardiorenal kidney disease and non-compliance in general. She had a remote ulcer on the right foot, which had healed after an angioplasty procedure, and her current issue was a left fifth toe wound. It was spontaneous gangrene. She had rest pain, so these are tough patients, and anyone with spontaneous gangrene, these patients can progress pretty rapidly. Prior to seeing me, she had an attempted revascularization via an endo approach. This led to not a very good situation, actually aborting the case. She was unable to lie flat. She became very hypertensive and went into flash pulmonary edema requiring admission with diuresis. She was supposed to get medically optimized in the interval to bring her back for an attempted revascularization with an endotracheal with a general anesthetic, and this didn't last very long because she came right back to the emergency room with worsening pain, very quickly advancing gangrene, white count, worsening renal function, and just not doing well. She had a slight troponin elevation on check. She was complaining of some chest pain, was deemed to have a type 2 MI, underwent not a very revealing stress test, but given the urgency of the foot, she did not undergo a cath and was deemed to advance to an endovascular intervention given being categorized as a high risk. So this is the patient's ABI prior to any intervention. She had a pretty good waveform and essentially normal foot on the right and very diminished ABIs and almost flat line at the foot with an ABI of 0.3, which is probably mostly due to her calcific disease. Her foot, I think some of us, particularly when you see an advanced gangrene this quickly, just happening within essentially a 1 month period, would say, perhaps we've already lost a foot. She has gangrene ascending already close to the ankle. So at this point, here I was being sent this patient who was very high risk from the community. What do I do with this patient? She was clearly not medically optimized. She still had kidney disease, of poor heart, volume overload, and she was refusing an amputation. We had a long discussion about the risks, certainly stating that I wasn't even sure if her foot could be salvaged and she might still end up with an amputation, but she wanted to proceed. And she needed a general anesthetic to even do an endovascular intervention. So I wish I could get to the punchline and tell you that I took her foot from here to here with a very straight line path, but that is not the topic of my talk. So every time I took a step forward, it was like I took 2 steps back with this patient, but we will try to get through this quickly. So here we are, first day, she had required a general anesthetic, took her to the operating room, we did an angiogram. She had actually pretty good inflow. We got into the groin and took a closer shot and look. She open profunda, but disease profunda, so already we know we're in trouble and we can explain the rapidly advancing gangrene in this patient. I probably should have had wider eyes and a lens focusing on this area, which is the common femoral, disease distally, just at the level of the profunda. But we kept looking, and I was maybe a little bit too focused on trying to get something done for her and get her off my table so she wouldn't have massive cardiac arrest or a heart attack. So here we are, we had lumen in the SFA. I said, well, I could put something through there. So we proceeded. We were there to do something, save her foot, so we did. I did. We spent quite a bit of time at the adductor hiatus, which is often the challenging spot. We got past this, used a combination of Viance and ultimately using an Outback device to get through this level. We obviously spent some time here, perforation, dissection, and you can tell by the contrast that lingers behind. Her outflow, I thought, wasn't that bad. She had popliteal, she had a little bit of disease in the TP trunk, but an open posterior tibial artery, an AT that ultimately became diseased and occluded at the ankle. So here we are, we start doing some work, putting in balloon angioplasty, our way back towards the common femoral artery, and balloon angioplasty down into that TP trunk with a 3 millimeter balloon. So, got to check on the way out. Well, we did. SFA, pop, all looked good, and now we lost our outflow. So here I was trying to save her foot, and clearly had tibial disease, and now we had no outflow whatsoever. Was this spasm? Was this thrombosis? Maybe a little bit of both. Did we embolized while we were opening up the inflow? We tried some ballooning. We tried nitro. None of that worked. So at this time, my approach to bailing myself out was putting a lytic catheter. I put a ProStream wire all the way down into that posterior tibial artery and just landed it there to lyse her overnight, and with some sheath heparin. So we actually extubated her because I was trying to avoid a prolonged anesthesia, and brought her extubated to the ICU. And in a very predictable fashion, she went into flash pulmonary edema. She required re-intubation. So now she was, not only did I get her intubation for the procedure, but now she's going to be intubated for 2 days. So cringing all my way back to the OR the next day, there's my ProStream catheter. We got back her PT, and you can tell that she had some intrinsic pedal disease. So this already is a poor marker, and it's with this patient that I think I changed my whole view on the angiosome concept. So we got back in there, we ballooned on our way out, we placed a drug-coated balloon along the POP FEMS area, and actually ended up with a fairly decent 2-vessel runoff. And on the way out, here I am, I spent all this time doing all this work, got her some flow, but here I am in that treacherous little middle of the ground area, I guess, if you would call it that. She had persistent, and I did not appreciate how badly this was, but she had persistent disease, which I chose not to treat endovascularly at the common femoral and into her profunda. So she did extubate, cardiology was involved, she had very good management of her heart failure and kidney disease, and I ended up with an ABI of 0.6. I like to check everybody afterwards, and this was certainly not satisfying. This was not going to be enough to save that foot. That foot was in trouble. And we did a TMA, and the foot was in trouble. And, marginal healing is a nice way to call this, but this is a very disappointing thing to look at when you just put this patient, when I just put this patient through a couple days of risk of a general anesthetic and intubation, all this stuff. So for a few days, we let her kind of settle out. Actually, her creatinine improved with good management of her heart failure, so that was encouraging. And I thought I'd lost the battle. So we had a long discussion with the patient. I, told her we still had some persistent disease that I thought would be best approached through an open endarterectomy and revascularization of her inflow to get her to heal this foot. And again, she wanted everything done, and she was actually looking pretty good, so we proceeded with that plan. In my mind, even if the outflow did not last very long, my goal for her was to give her back a functional amputation, whether that's a TMA or BK, and I knew no matter what, down the road she needed good inflow to at least heal and save a BKA, so I thought it was worthwhile. So ultimately, we did that, and actually now we're in a better place. Her ABI is near normalized. She had good flow, and after much debridement, revisions, grafting, and IV antibiotics, she did ultimately heal this foot. She is walking and actually did stop smoking. But for me, this patient was certainly not a tibial complication, but more of a tibial nightmare, because that was, the main vessel. And when we're trying to save limbs, and for those of us that really spend a lot of time with CLI, these are tough cases. She was actually able to tolerate more general anesthetic than I gave her credit for, than any of us gave her credit for, but I think, that's hindsight. You can't predict that ahead of time. I think I would have done things a little differently if I had known that, and I would have, done this with a hybrid approach where I approach it through the groin and then in an antegrade fashion revascularized her SFA, maybe had spent less time, maybe not lost my outflow, and at the same time do a TMA. Certainly we have patients we do this for, and when you do it all in one shot, it actually does, they do very nicely. So when doing a long inflow procedure like this in someone with tibial disease and a single vessel runoff, just beware, keep that in the back of your mind. There's a good chance if you spend a long time You may lose that outflow, and prepare yourself to bail yourself out. Have things at hand, have them in the background, even if it just makes you feel better if you need to do thrombectomy or lysis. Use self-restraint. Just because you can put a wire and a catheter in it, like I did, doesn't mean that should be the first thing to do. In my algorithm, stick to an algorithm and keep it safe. And then again, this patient really taught me the concept of angiosome. I think there was probably additional work we could have done in her pedal arch, and that's something that she did not get, but maybe that would have enhanced her recovery and got her quicker to a healed TMA. So that's what I have. Thank you very much.